We are
So
live now.
thank you all for joining this clinical meeting of East India Spine Society. This is the second clinical meeting and first one to be aired in Ortho TV platform. Ortho TV is a digital academic platform of orthopedic surgery in India, and it is aired all over the world. So this meeting is compared to the first one can reach a better audience and wider audience. So topic of the today's meeting is TB spine. I am Dr. Chinmoy Nath from Kolkata. I along with Dr. Jitendra and Dr. Sachlang DebBarma and Dr. Montu Join will moderate this session. There are 5 presenters from different states. The first presenter will be Dr. Subhadeep Mondal. He is there already with his case. And the second presenter is Dr. Aditya Prasad Panda. He is joining a bit in a few minutes from Bhubaneswar. Dr. Lalrinmawia is there. He is a third presenter from Aizawl, Mizoram. The fourth presenter is Dr. Sanskritya from Jharkhand. Fifth presenter is Dr. Gautam Prasad. He is still there. He is from Patna and Bihar. And the panelists are Dr. Abrar Ahmed. Dr. Ahmed is already joined. He is one of the senior most spine surgeon from Kolkata. Dr. Kiran Mukhopadhyay is joining in a few minutes. Dr. Jitendra Raut is joining. Dr. Gurdeep Das is from AIMS Bhubaneswar. He is joined. Dr. Jitendra Raut is the secretary of the Odisha Spine Society. Dr. Rajeev Anand from Bihar will be joining. Dr. Tankeswar Baruah from Assam. He is actually working in VIMS, New Delhi right now. He has already joined. Oh, Dr. Jitendra has joined. Dr. Sudhir Kumar is a senior spine surgeon working in Ranchi in his own hospital. He has already joined. And also Professor Dr. Mahesh Prasad. Dr. Sudhir Kumar is also professor. So let us start the program. Our program is supported by Ortho TV team of Dr. Ashok Shyam and Dr. Niraj Bijlani from Pune. So let us start with the presentation. But before that, I want a short introduction by Dr. Abrar Ahmed and senior panelist and Dr. Sudhir Kumar. Dr. Ahmed, please, just one or two sentences.
I think this is it's a very sincere endeavor to spread the knowledge of spine in the Eastern India, and that's why we have made this East India Spine Group. And last time meeting, which we did last month, was very successful, and we discussed among ourselves and to make the these case presentation for to reach wider this thing audience. We have requested Ortho TV, and they have acceded to our request, and I welcome all of you presenters for the second clinical meet of the Spine Society of Eastern India Group, and I will ask the first presenter to present his case. Thank you very much.
Thank you, sir. Dr. Sudhir Kumar, please, a few words. Kumar is not audible, I think.
Yeah.
So
now am I audible?
Yeah, right now you are audible.
Yeah.
Just a few words before Subhadeep will be presenting.
It's all the best for all the speakers and to our society same time.
Thank you very much, Dr. Professor Sudhir Kumar. So may I request the first presenter of this session on TB spine, Dr. Subhadeep Mondal. He is Associate Professor of RG Kar Medical College of Kolkata. So Subhadeep, please. You will have 5 minutes for presentation and 10 to 12 minutes for discussion. This case, you go full screen mode. You are not audible, Subhadeep. Subhadeep, you are not audible.
Unmute.
Unmute you. Yeah, it is. He is unmute, but he is not audible.
In case he is having any technical problem, ask the second presenter to present, and he's there. Yeah,
think
Subhadeep.
another presenter who is available already there is Dr. Mawaya from Aizawl, Mizoram. So,
Sir, am I audible?
Yeah,
yeah,
okay.
right now there is.
Okay.
Sir, am
Please
I
start
audible?
presenting.
Yes, yes.
Yeah.
Yes. Okay.
Just
Sir.
start.
Thank you. So myself, Dr. Subhadeep Mondal from Kolkata. So I'm going to present the first case. So in June 2024, a middle-aged female from Howrah came to my OPD with a history of chronic low back pain for last 3 years, which has been aggravated in last 6 months. There is difficulty in standing for last 6 months, and her sitting become painful for last 2 months, and she is bed bound since then. She didn't develop that much of weakness, and the bladder bowel control was present. So on examination, I didn't found any gross motor weakness in her limbs, but there was significant
Slides are
perianal.
not coming. The slides are not coming.
Huh?
Your slides are not coming.
Your slides are not moving. You go to the full screen mode. Yeah, right now.
Now it's fine.
So now you can see. Am I visible?
Yeah.
Yes.
Yeah, it is visible.
Okay. So in June 2024, a middle-aged female from Howrah came to my OPD with a history of chronic low back pain for last 3 years, which has been aggravated in last 6 months. There is difficulty in standing for last 6 months, and sitting become painful for last 2 months. She was bedbound since then. She didn't experience that much of limb weakness, and the bladder bowel control was present. So on examination, I didn't found any major motor weakness in her limbs, but there was significant perianal hyposthesia. She was anemic and malnourished. Weight was just 42 kg. So on the right hand side, you can see the entire MRI where there is significant destruction at the lumbosacral junction is clear. There is a destruction of the L5 vertebra as well as the sacrum, and there is a significant soft tissue shadow as well. On further image, you can see there is osteolysis and destruction in the cervical spine and in the proximal thoracic vertebra as well. So the other MRI images, both T2 and T1 and the star images show there is significant destruction of the lumbosacral junction with the appearance of the psoas abscess as well as osteolysis in the L5S1. So on further inquiry, I found a MRI which has been done in February 2022, which had shows gross destruction of the lumbosacral junction, the psoas abscess, and this MRI shows that the L5 vertebra is still present. So on history, she was on anti-tubercular drugs for last 2 years, but she was on irregular medication due to frequent gastrointestinal side effects and malabsorption issues. I didn't found any document regarding the attempt of biopsy from the lesion at that time. So therefore, the document of any gene expert and the culture sensitivity report was not found. So currently at that time in June 2024, the local X-rays showed there is almost dissociation of the lumbar spine with the sacrum across osteolysis as well as osteoporosis in the surroundings bone, and the whole spine X-ray shows both coronal and sagittal imbalance. Sir, should I continue?
Yeah.
Okay. So at that time, the question is how to proceed in that scenario. Should I continue the conservative treatment as it was following? Do I do a biopsy first and then conserve the scenario? And the other options are proceed for the surgery, that is through posterior stabilization and debridement only.
No, please stop.
Yes.
Please stop.
Yes.
let me ask. May I ask Dr. Jitendra, what is your opinion of further management?
No, because this is the latest MRI, no?
Yeah.
This MRI is the latest MRI because he is taking treatment since last 2 years, you have told. Subhadeep?
Yes. Yes, this MRI is the latest MRI.
Latest
in
MRI. So
June
I think we should do a
2020.
biopsy. Either you can do a CT guided biopsy or a ultrasound guided biopsy. Then, because already he's taking 2 year irregular treatments and this is the latest MRI, it's not healed. So I will prefer to do a biopsy. Then after that, we'll decide the treatment.
Dr. Tankeswar Baruah?
Hello, hi.
Dr. Baruah?
Yes, biopsies must in this juncture. In fact, any tuberculosis, we should give a try, attempt for biopsy. But it might not be feasible in all places everywhere. But still, in this scenario, biopsy is important at least to rule out drug-resistant tuberculosis. Yeah.
So what are the things,
And
what are the investigations you ask for with the while you send the material to the pathologist?
see. So the first is microbiological. Any kind of microbiological. As we are suspecting or you are thinking on the line of tuberculosis, of course, sample for AFB culture and drug sensitivity test. And if we are sending inside our government centers or in public hospitals, then we should go ask for gene expert. And also we should request to keep sample for LPA test. And we should ask for fungal is very important. Sometimes in long-standing cases, it might not be tuberculosis, it might be something like fungal, or if the patient is having some exposure walking in a horse crowded areas, then we should think of brucellosis also. And these are first. And histopath, if we get adequate sample, obviously we should ask for histopath. And in histopath, we should always mention that kindly look for AB stain if possible, and also for PAS stain for fungal. That I usually practice here in sub-region. Thank you.
Dr. Gurdeep Das, are you there?
Good evening, sir.
Good evening. So what is your take at this step?
I think the patient is in severe pain, and if I heard correctly, there is also some amount of deficit. I mean, I agree. Biopsy, we can go ahead with biopsy, but I think at this point we are not considering any tumor or malignancy in our differential. So we are probably thinking whether it is a pyogenic or it's a tubercular infection. So we are dealing with an infection, whether it could be fungal, like Tankeswar sir said. It could be fungal or pyogenic or tubercular, but it is mostly infection. So I think we can straight away go ahead, plan an intervention where we will collect some specimen for biopsy, send for culture, and at the same time address the problem that the patient is facing. But I agree, if somebody plans to go ahead with the biopsy first and then plan the definitive management, that is also a reasonable plan.
So you are in favor of directly intervening and while doing your definitive operation to take the biopsy along with it, right?
Yes.
Okay. Now, may I ask Dr. Abrar Ahmed, what is your
I think
take, sir?
that is what we have to. The thing is that patient is already taking ATT since last 2 years, maybe irregular one. The thing is that we must rule out. First thing is that whether we have to do some serology just to rule out HIV and other infection. Why? Just to rule out whether the patient is immunosuppressive or not. And it's very important to start any sort of treatment to do the biopsy. In our setup, what we do, we take the biopsy ourselves, and we send all the tissue material for histopathological examination, gene expert TB, bactec TB culture, pyogenic and fungal culture. Along with, we take the slides for AFB and gram staining. So these are the basic things which we do before, because the patient is suffering for a long period of time. We have to plan the things accordingly. If it is MDR, then the treatment is entirely different. Then we have to, start the different sort of antibiotics, because if it is MDR and we do the surgery without taking into consideration the drug resistance, then this disease is going to progress over a period of time. So it's better to plan properly before doing any sort of surgical intervention. Definitely, there's a infective instability at the lumbosacral junction. We have to tackle that thing along with the problem higher up. The main problem is that the spine is not able to carry the load. Patient has got long-standing infection. There's an instability there. So we have to sort out that thing. We have to plan accordingly. We have to get a CT scan done, and the MRI is already there. And then accordingly, once the culture report, other things they come, because now the gene expert TB culture report comes within 24 hours. Bactec TB waits for another 10 or 15 days, and the actual culture takes on to maybe 6 weeks or so. So that will give us an indication before starting any sort of treatment to have the basic, things in place. That's my opinion.
There are two thoughts. One is directly by Gurdeep told that he wants to directly intervene and then take biopsy and proceed accordingly with the biopsy report. And Dr. Abrar Ahmed and others, they told that they want to do the biopsy first and decide according to the biopsy report which type of infection it is, and then tackle the instability along with the infection. So, Dr. Sudhir Kumar, what is your opinion in this regard?
Yes, I would like to get a CT scan done first, and followed by I would like to go directly for the intervention along with the stabilization, so that you are going to get an adequate amount of the tissue for the further analysis. Anyway, for the instability, you are supposed to stabilize the spine before embarking on the, or same time you can embark upon the medical treatment too.
Dr. Kiran Mukhopadhyay has joined. Kiran, what is your take?
So I will go with Dr. Ahmed. So I will take biopsy first, and I will wait for a couple of days or a few days, and accordingly then after that I will,
report will proceed.
Yes. After that I will go for fixation and definitive management.
So there is no doubt that this is a very unstable situation in
Yes.
effective instability, and we have to stabilize it. But before doing any stabilization process, we have to be ascertain that whether it is an MDR tuberculosis or it is a fungal infection or anything. So may I ask Dr. Subhadeep Mondal, what you have done in this case to show?
Sir, regarding this scenario and the discussion what the seniors have told, so here the first point is to establish the diagnosis that whether it is TB or not, and then to establish whether it is drug resistant TB or not. And after that, I have to stabilize the lumbosacral junction for the rehabilitation of this patient. So I did both the things simultaneously, taking the biopsy and did the stabilization surgery at the same time. And I got the gene expert report on the very next day, within 2 days. So regarding the surgery, there are multiple options. Do you want to have a discussion on that, or I should?
No, definitely. We want discussion on that thing. That is very important.
Yeah, definitely.
Yes.
There are a lot of
please.
different opinions about the stabilization process, and
so these are the 4-5 options, surgical options here. So you can carry on the discussion. So this is the latest X-ray. So this is the latest X-ray of this patient.
This is the latest X-ray. So Dr. Gurudeep, what is
yes,
your
sir.
plan of management after?
Sir, if I can see correctly, there is a big void in the L5S1 area, and I think the disease has been quite there for some time. So there would be significant osteoporosis. So I would probably plan a spinopelvic fixation over here and be ready with bigger size cages to fill that void. So my plan would be I will be going below I'll be going to S1 and then ileum below, and above, if I am happy with L5, it is fine. Or if needed, I may have to extend the instrumentation to L4. So my standard plan would be to go from L4 to ileum, and the void there, I will be ready with iliac trace graft And allograft, if I feel that the size of the void is more than 16, then I think any case, none of the cases would be sufficient. So I will try to pack it with a tricortical iliac crest graft and see if it gives some stability.
So you are planning to go to, definitely we have to go to the pelvis.
Yes.
Whether you are doing an S2AI screw or older generation iliac screw.
I prefer the S2LR iliac screws because they are in line with the lumbar screws. So I do not have to use any offset connectors. But both the options are available. I mean, it's on the day. And if my first preference will be S2LR iliac screw.
For Dr. Abrar, you are the expert on spinopelvic fixation.
I think before undertaking surgery, I will like to get a recon CT scan done to know the extent of destruction there, and then accordingly I will proceed. If there is a very significant destruction of S1, whatever, then I may not be able to put the screws in the S1, whatever. If there is a very significant gap at the L5 S1 junction, then I have to plan whether I have to fix purely from the posterior aspect and then put if there's a very big gap, we have to fill that gap with the cancellous bone. That's fine. So my first thing will be I will always take a CT scan first and then decide.
Then Dr. Sudhir Kumar.
I will go for the spinal pelvic fixation, DebBarma, and same time if possible, we'll like to put the cage from behind, or otherwise we'll like to split the surgery in two parts. One is the DebBarma.
Is there anybody
followed by the
preferring fibula graft to fill this large void?
No, I don't think fibular graft will be that much. That's why we have to get the CT scan done to know the extent of bony destruction. It's very important because that thing is not visible in the MRI clearly. So once I've got that, suppose there is a significant bony destruction. Obviously, you have to have a hold in the iliac crest. Without that, you cannot stabilize the lumbosacral junction because there will be tremendous forces. If you just put the screws only in S1, the whole of the implant is going to fail. So you have to go at least 3 segments higher up because it is a lumbosacral junction has got a lot of strains when the patient will be standing. So at least I will go 3 levels up, and then I will have a hold in the iliac crest. If the S1 I'm not able to put the screw in the S1 region, then I will put the two. I will have the dual fixation. I will put the two large screws in the iliac crest, and then I will connect that thing with the offset connector. And if there is very significant gap, then I will accordingly I will flip the patient and have either in the same stage or single separate stage to go from the front and stabilize from the front with a large chunk of iliac crest graft, and may fix it with some screws to the underlying vertebrae. That's my planning.
Thank you very much. So, Subhadeep, please show, because there are other cases. Please show what you have done.
So, I did the CT scan, but the images are not present here. So, what I did, the posterior pedicle screw instrumentation, the L5 vertebra was very much mushy, and it was destroyed, as well as the sacrum, the S1. So, I didn't got any hold in the L5 as well as the sacrum. So, I did pedicle screw instrumentation at L3, L4, and the S2LR ilia. I did thorough debridement through the S1 pedicle and packed a good amount of autogenous bone graft at the lumbosacral junction. I picked up the graft from the both iliac crest, and after debridement, I packed the graft in the junction, and the debrided material were sent for investigations. So luckily, the Jain expert came out to be tubercular positive, and no signs of rifampicin and INH resistance was found. And the material was sensitive to all the level 1, the first level anti-tubercular drugs. So with the help of a pulmonologist, the rebooting of the anti-tubercular drugs was started, that the first 4-drug regimen along with the levofloxacin, and I put the patient on teriparatide from day 1. So this is the X-ray at the 3 months, and this
Very
X-ray
interesting.
is at the 8th month. So at the 8th month, there is the fusion mass at the lumbosacral junction has started to solidify, and she is now walking comfortably with the help of a brace, lumbosacral brace, and her sagittal and coronal imbalance has got corrected. Currently, she is on 3-drug regimen, anti-tubercular drug regimen as well as teriparatide, and her constitutional symptoms has also improved a lot.
So, may I ask Dr. Tankeswar Baruah to comment on this surgery?
Sir?
To
Okay.
comment on this.
Okay, fine. Actually, my opinion is same with Dr. Abrar Ahmed, sir. I probably would go for Ilias Cruz, if possible, double Ilias Cruz. But still, fair enough. He did a beautiful job here. And I think in tuberculosis, if the drugs are responding, healing is sometimes is not an issue. It heals very well. So, one questions I want to ask the presenter is teriparatide is a standard or recommended in the tuberculosis? Because some people they use, I don't use in TB, and what the other panelists says about teriparatide use in tuberculosis. What's fine?
So, sir, the teriparatide I have used to address the osteoporosis in this patient, and
No, no,
at the
that's
same,
fine. That's fine. Some other people also use, but what
yes,
the evidence says using teriparatide in tuberculosis? Any evidence on this?
I had seen few case reports on starting
Okay.
the anti-tubercular drug and
No study.
teriparatide
There is,
from day 1.
I have not seen any study. Some
There
people
are
are
few
using,
case
but
reports present in
yeah.
present. You can search that there are few case reports, because the teriparatide will promote the osteogenesis, and this graft at the lumbosacral junction is providing some structural support as well, but it needs to solidify. So that's why, and to protect and to address the osteoporosis in the generalized spine, in the lumbar spine as well as the sacrum, I started the teriparatide. And I also had put the rods are the cobalt chromium rods, not the standard titanium ones.
Okay.
See, there is an issue of since this patient is not walking for a long period of time, so you assume that the patient is having secondary osteoporosis.
Yes,
Means
sir.
if you get the bone density done, you will see that the Z score is more than minus 2.5.
Yes, sir.
And what we have seen in these patients is, if you start it, there's no contraindication to start injection teriparatide if the PTH level is normal. It is going to improve the extent of this secondary osteoporosis in these patients. And what we have seen in many cases of our pyogenic infections also, and those patients who have got additional BMD, bone mineral density done, and they are osteoporotic or they have got secondary osteoporosis, it helps in those patients. So I think though the evidence is still lacking, I think we can start a study on these things in some institutions, especially in the government institution. To we can have a observational study or a comparative study. One group of patients.
Yeah, we can do that multicentric study in the Eastern India.
We can start that sort
Yeah,
of study.
it's a very nicely said. Yeah.
Yes.
Okay.
Yeah. So thank you very much for the nice case. So we have to move on the second case, second presentation.
Thank you, sir. Thank
Subhadeep,
you all.
please unshare your screen, and the
Yes.
second presenter will be Dr. Aditya Panda and Aditya Prasad Panda. He is from Bhubaneswar, Odisha. Aditya, please share your screen and start presenting.
Sir.
Aditya, are you there?
Sir, I am there.
Yeah, please share your screen. It is there. The previous screen was unshared. Now share your screen from the downstairs. There is below there is a bar, and the center of that there is a green button, share button.
Yes, sir, I shared it.
No, it's not visible.
Okay. Sir, can you
Yeah,
see anything?
it's coming. Yeah, it's coming. Yeah. Yeah, it's visible. So start presenting.
Good evening, teachers and my colleagues. Today I am going to present 2-3 cases how in which mostly the anterior vertebral body is destroyed in the TB, and how we manage those cases. So this is the first case. Sorry.
Yeah, go to the next slide. Yeah.
This is the first case. This is a 36-year teacher who presented with a painful lower limb paraplegia, which is progressive in nature since last 1 month. Her bladder is catheterized on presentation. Sensation was partially present. Knee reflex, ankle jerks, Babinski signs are present, and reflexes are exaggerated. Inflammatory markers ESR, CRP is increased. ESR is 80, CRP is 52, and X-ray shows D10 vertebral body destruction. So can you able to see the MRI?
Yeah.
So in the MRI, we can clearly see there is a pus present anterior to the vertebral body, prevertebral abscess, then epidural abscess. There is a large subligamentous spread from D8 to D12. Pus. D10 vertebra is completely destroyed, mostly the anterior and the middle column. The posterior ligamentous, there is a posterior epidural abscess from D9 to D10. So,
what is the neurological status of this patient?
sir, patient in SCA-B, the motor complete paraplegia. Some sensation is present. Bladder is also affected.
Okay. Yeah.
So it's a
Continue.
clear-cut case.
Carry on, please.
So is the abscess, it shows it is an infective pathology. It is not since any malignant pathology, because pus is there, vertebral body destruction is there, paradiscal in nature. So there are many surgical options. Some surgeons, they can choose anterior options, posterior options, and some will do combined options. So now the case is open for discussion. What others want?
So may I ask Dr. Sudhir Kumar to proceed, please, with this case, the discussion. Dr. Sudhir?
Yes, you can go ahead.
Okay.
So do you outright go ahead with the surgery, or you want to get a tissue diagnosis first?
I will like to go ahead with the surgery. I do prefer to go ahead with the surgery. If you are suspecting too much of the bony destruction, before that I will like to go for a CT scan done to know about the status of the bone, and I do prefer the surgery before really embarking on the tissue diagnosis. Anyway, they do require a tissue diagnosis along with the stabilization.
Dr. Tankeswar Baruah?
Yes, actually, biopsy in this particular case, the immediate urgent need of surgery is decompression because he is having paraplegia during bladder involvement. And at the same go, we can go for tissue diagnosis, of course, rightly said by Dr. Sudhir. Yeah.
Dr. Aditya, please proceed with what you did in this case.
So all our friends are agreed for surgery, there are 3 approaches: anterior approach, posterior approach and combined approach. So I want to know any different idea from any of our colleagues. Anyone want to go only anterior? Anyone want to go only posterior, or some they want combined approaches?
See, nowadays, by and large, I think all most of the people's spine surgeons are they in spine TV they go posterior only with decompression whatever way, and mostly tense pedicular decompression. And as this patient is having epidural abscess, so though we don't prefer laminectomy in almost all the cases, and also as this patient is having neurological deficit severe, we might consider for laminectomy full. Otherwise, we do usually have laminectomy. And fixation is 2 to 3 ups and downs according to the strength of the bone. Cut the pedicle, drain out the pus. If there is no destruction, leave it there. If there is some destruction or there is void is there, we have to reconstruct. That is the standard way we follow.
So it is the rightly said by
most of the spine surgeons right now prefer to go posterior with anterior reconstruction by a mesh cage or by a expandable cage from the back. What Dr. Abrar Ahmed?
Yeah.
Dr. Ahmed?
I think in this patient we will go from the back side because it's a D10 level. If you can sacrifice one of the D10 nerve roots and go from the side and put a cage in there, and go 2 level at least up and 2 down, and compress the cage.
And Dr. Kiran Mukhopadhyay?
Though I am fond of doing anterior surgery, but in this case, as this is a weight lesion, so I will prefer to go from back. But before that, as Dr. Sudhir Kumar told, that I will like to see a CT scan in this patient also, because if I want to, I have to do an anterior reconstruction. So it is better to have an idea how much bone has been already destroyed. So my takeaway, I will from back and a long segment with anterior support if needed.
So it's a one stage combined approach, sir.
Yeah.
360 approach, one stage. Yes. So we did the same. We approached the same thing, but little different. So there are 3 options. There are posterior only surgeon group of surgeons. They do 2 above, 2 below, D7 to D12. Few may agree with 3 above, 2 below, 3 above, 3 below. As most of the senior surgeons, they agreed for the combined posterior and anterior options, like 2 above, 2 below with D10 to D11 mesh cage. Sir, it is a transthoracic. Mostly surgeons are preferring lateral extracavitary approach. So there are many options. So surgical plan. But we did a little bit different thing.
Most of the panelists are preferring the posterior only transpedicular decompression with sacrificing their D10 root and putting either a mesh cage or a better expandable cage. So what did you do?
So what we did, sir, we have previously this screw. This is a different type of screw in which it's threads at the tip and which can hold a cage, like simple Phillips cage, bullet cage. So we first we exposed. We did a hemilaminectomy on one side, and we did a transpedicular and transfacetal decompression. Then we inserted that cage through the transpedicular route to the anterior half of the vertebral body to work as a load sharing device. So global reconstruction was done from the posterior transpedicular cage.
No, that is a good option when the lesion is limited. If it is a very significant or large lesion, then this cage may not fit there. It's a good idea if there is a 10 or 15 millimeter, defect there. But if it is a 20, 30 millimeter defect, then either you have to put these 2 cages simultaneously.
You can use 2 cages from simultaneously from both sides,
from
both sides.
One transdiscal and one transpedicular.
Pedicle, yes, sir.
That you can do, but so Otherwise, for small defect, this is a very good idea. I think this is going to hold.
It is
It is
very
a nice
difficult
idea.
to engage both the end plates.
Yeah.
Is it expandable, or it is a
No.
just like a TLIF cage?
It's a TLIF case, sir.
It is not expandable, but they can
It is
modify.
not expandable.
They can modify it.
Yeah, they
And
can
the main
modify it to become to make it an expandable cage. Then both the end plates will be possible to be engaged. Then it will be
There
more
is
fruitful.
I think this should work very well in the trauma cases.
Yeah.
Understand whether a burst fracture or something like that, that you can do very well. This cage is going to work very well in those cases. You go transpedicular and fix it there, because there the defect is not very large, burst fracture, other things. So this is
Where
going to
do you
work
like to
very
place
well
the cage?
in those cases.
Is
In the
quite
front.
anterior.
Yes, sir, because psoas, because of the prevertebral abscess, the psoas is went very anteriorly. The aorta is displaced anteriorly.
No, where is the psoas? It is in the D10,
Sorry,
11.
no, sir, aorta. The aorta is displaced very anteriorly because of the prevertebral abscess. So that's why we knowingly put the case little bit anteriorly so that we can share the load.
No, this is a nice idea. This is a very good
What is the
innovation.
preferred area for the placement of the cage?
Where the bone is good, not
Where
on
the
the
bone is good.
softer bone. We need a
Okay.
good bone support.
Can I put one question, please? It's Dr.
Yeah, sure.
Sachlang online.
Yeah, Dr. Sachlang, where?
Yeah, so sorry, I came late.
You are in the moderate.
Yeah.
Please.
No, the defect being very small, can we just go with a standalone stabilization in these cases? Because more the kyphotic angle might be hardly less than maybe 10 to
No.
20 degree, I suppose,
It is
in this case.
The thing is
No, sir.
that this is a wet case. You can just simply do the decompression and put the 4 screws, the 8 screws above and down. And since if it is a gene expert positive and there is no resistance, it's going to heal very well. Majority of these cases they heal very well. If there's a very significant defect, then you just may simply put the cancellous bone graft there, impact is there. And this is an innovation, new innovation. This is a good idea, and that can be tried in various pathologies. And this is going to be a good armamentarium, additional thing. So this is a great idea from my side.
So what is the function of the screw? Just to hold the cage in position?
Yes.
sir. So that you know, because cage migration is a big problem. Cage fit and cage migration. Young surgeons, they don't know how to do extracapillary approach, or those want to do anterior stabilization. This is very
This
minimal
is good
invasive.
for good for the L5S1 region because majority of the cage retrobulsions that happen at L5S1 region, and you do a T-lift there with this device and fix it with the rod, then it's not going to migrate.
Yes.
The new thing, I think this device also needs a big study, multicentric study. Very new thing, but you have to modify. I think you have to modify the cage, asking ask the companies to modify it and to
Modify
make
the
it an
screw tip.
expandable.
First
Sorry,
you
it's
get a
not very difficult.
patent it in your name, and then
Yes,
you
sir.
modify it.
Yeah.
So
Patent in
these
your
are the
name.
various options. So I named it as a pedicle case. This is a novel design, articulating the pedicle screw with the different size of cage, which is a boon in spondylodiscitis and osteoporotic fractures, as rightly said by Abrar Ahmed sir. So this noble pedicle cage strengthens all the 3 columns and it connects all the 3 columns. But the shortcomings of mesh cage is it is grossly invasive procedure requiring surgical expertise, thoracic root sacrifice, lateral dissection, excess blood loss, and increased operative time, and sometimes pleural injury in unexperienced hands. So inserting a case through the pedicle is minimal invasive, it is less operative time, and has minimal risk of displacement. So as the advantages are, there is no need of lateral dissection, reeve resection is avoided, less blood loss, less operative time, no implant failure. But the demerit is the case height is fixed to the 8 mm because the pedicle height maximum is 8 mm at the thoracic area.
Yeah. So Yeah, you try to take your patent and then
Sir, I held the patent, sir. It's 2 years.
your
I
patent.
got
Okay.
this patent
Okay, very
last
good.
2 years.
This will be good for
Okay,
the
very good.
transforaminal fixation.
Sir.
Mm-hmm.
Just I want to see the similar case. We have we did a TLIF at L1, L2 level, but as sir told, when the TB is in the wet phase, putting a cage in that wet phase sometimes loosens the cage, and cage subsides in 2 months. So this type of complication can be avoided with pedicle cage construct. So just I will present another 2 cases. It's a D9 tuberculosis of vertebral body destruction, presented with kyphosis, patient in SCIB and bladder involvement. Similarly, D9 cage, pedicle cage fixation was done, 2 above, 2 below, not required 3 above, 3 below. So sorts. It is another case of D11, D12 spondylodiscitis, tubercular, with D11 completely destruction with kyphosis around 30°, in which we used a cage to reconstruct the D12, D11 vertebra. So all the patients, they improve, and till now there is no cage subsidence or a cage disengagement from the pedicle screw is we have seen, sir. But we have only 5 cases. So this is how we do. We first expose on one side, do unilateral pedicle screw fixation, hemilaminectomy, cord decompression. Pedicle is dissected and marked. Traversing exiting nerve roots are identified. Biopsy is taken from vertebral body, and pedicle cage with bone graft is impacted through the pedicle into the vertebral body. So this is used in staphylococcus and other pyogenic infection, trauma, osteoporotic fractures, tumors. After complete resection, we can try, but I have no experience with tumors. This is also.
Anyway, there's a great series. Next time you present a large series, we invite you to our conference in Calcutta.
Sure.
Present your series there. Okay.
This is my patent. Yes, sir.
Thank you very much. It's a very nice case. So we have to move on to the third case. That will be presented by Dr. Lalrinmawia from Aizawl, Mizoram. So, I request Dr. Aditya Panda to unshare your screen. And Dr. Sachlang is there. Dr. Sachlang, please moderate this next case.
Okay. Sir, can you just go ahead, sir? Because I'm not very well today.
Okay. Thank you. So, Dr. Mama, please share your screen.
Okay, trying for the second time. I have problem actually sharing the screen. Let me just try with a few minutes.
Yeah, it's there. Your screen is shared.
Not disappeared.
No, first you have to, your screen is shared, but your presentation is not there here. You have to open your presentation first, then share the screen.
Is it coming?
Yeah, it's coming.
It's coming.
It's there.
Okay.
Yeah, it's there, visible.
All right. Good evening, everyone. Very thankful for the organizers to allow me to present my case. So coming to the case history, a 20-year-old female comes with the presenting complaints of pain at the lower back, radiating to the right gluteal region, back of the right thigh and the right leg since the past 1 month, with difficulty in standing and walking. There was no history of trauma, fever, no numbness of the legs or abnormal sensation. There was no history of TB or any other chronic infective disease in the family. On examination, the patient walks with antalgic gait. There was local tenderness at the right sacroiliac joint on deep palpation. The Faber's test, the Ganslen's test, and the pelvic compression test were positive. No neurological deficit was there. And on investigations, the complete blood count shows mild anemia with raised ESR. The chest X-ray shows right upper zone pulmonary infiltrates. The sputum for AFB and CBNR was advised but not done. Ultrasound normal, and the CT also reconfirmed what was found on the chest X-ray, which is the right upper lobe consolidation. An MRI of the right hip shows right sacroiliitis with minimal collection along the inferior margin of the right sacroiliac joint. Ultrasound guided fluid aspiration of the collection at the right sacroiliac was advised, but not done as there was not enough localized collection for aspiration. So based on the clinical, hematological, and the radiological findings, patient was started on the 4-drug regimen antitubercular therapy, including rifampicin, isoniazid, pyrazinamide, and ethambutol. No improvement was seen after 2 months of ATT, and then a repeat MRI was done, which shows large collection size 10 into 5 into 2 centimeter along the submuscular plane of the right iliacus muscle. So drainage was done, and the pus was sent for aerobic culture and sensitivity, and the granulation tissue was sent for histopad examination and CB-NAT. Histopad came out with granulomatous inflammation with Langhans-type giant cells with areas of cases necrosis, which is suggestive of TB. And the stain for the AFB is also positive. And on CB-NAT, Mycobacterium tuberculosis was detected and RIF resistance was detected. So MDR-TB of the sacroiliac joint was diagnosed, and 5-drug oral therapy was antitubercular therapy was started from the District Tubercular Center, Aizawl, Mizoram. The duration was for 18 months, and patient is doing well even till today. Shall I proceed?
Just wait.
So
The thing is that initially you are not able to take out any sample from the lung.
Yes.
I think in our setup, I don't know whether it is available in your setup or not. We asked our chest physician to do a bronchoscopic lavage. If you're not able to take any sputum and if you're not able to take any biopsy from the sacroiliac joint, or the tissue is inadequate, or there's not a very significant amount of soft tissue abscess, the best thing is to ask your chest physician to do a bronchoscopic lavage, and that can be sent for the tuberculosis culture and other things.
Right.
So very good input, and Dr. Ahmed, and then Dr. Kiran Mukhopadhyay, what is your take?
What is the question?
The thing is,
what is your since he was not able to do a tissue diagnosis at the outset of the therapy, he has started the therapy on clinical and hematological and radiological evidence. So is there any other? Dr. Ahmed told that the bronchoscopic lavage in Apollo, it is available. The chest physicians are very good. They do bronchoscopy regularly, and they can do a bronchoscopic lavage and take samples from that, and it is easy. But it is not available in everywhere.
It's a difficult situation for those who don't have the facility. So for those, so we have nothing to do, but we are facing the situation that on clinical radiograph basis, we have to start the ATD. If we don't get the tissue sample and we don't have these facilities to get at the bronchoscopy lavage material. So I think this is a situation when we have to follow what Dr. Lalrinmawia was what actually followed.
That's fine. If you don't have any, If you don't have the facilities, you have no other option but to start on the basis of clinical finding, the empirical validity. That's fine. But the thing is that now your problem is with the multi-drug resistant tuberculosis. So that is one of the issue. Okay.
Yes, sir. Shall I proceed, sir?
Yeah, proceed.
Yeah. Proceed.
So, sacroiliac TB is, according to the literature, it's quite rare. Only around 5 to 8% of all the osteoarticular tuberculosis, which even that accounts for just about 1 to 3% of all cases of TB, according to SM2 research. And these are the usual clinical presentations. They are usually vague, non-specific, and the natural history is usually bony and kyphosis. And I must add that we are lucky to isolate the organism and the tests come out positive. These tests, they are quite the clinical presentations. They are quite non-specific, buttock pain, and provocative tests for the SI joint. They are all comes out positive. And this is just for the literature, the classification of the sacroiliitis according to X-rays. In type 1, there's widening of the SI joint. Type 2, erosion. Type 3, destruction. And type 4, abscess, which are found on MRI. So diagnosis is usually based on the smear microscopy for acid-fast bacilli or the cytology, if possible, by the aspiration. If not, if there is not enough material for aspiration, then we go for the open biopsy and microbiological examination of the tissue, whatever was taken out. So the diagnostic of choice is CB NAT and line probe assay, first choice. If it's not possible, then the liquid culture isolation and the line probe assay drug sensitivity test, and the liquid culture isolation and liquid drug sensitivity test. So coming to the treatment, usually most of the private practitioners out here in Mizoram, they prefer to treat the tuberculosis themselves. But I must say that it's better to, leave at the hands of the people who are within the program, because there has been so many programs in the past few years, like the Index TB guidelines, the PMDT guidelines for drug-resistant TB, and there are the WHO guidelines also, and the latest are the 2022 and the 2024 updates, which are a bit complex. It's not that difficult to understand, but to do it on your own and having a long follow-up, sometimes it can become quite difficult, if not program-based. So I must conclude that sacroiliac joint infection presents diagnostic dilemma, as they have vague and non-specific clinical presentations. A clinical diagnosis usually includes a thorough history and meticulous examination. If there is abscess, it should be drained, and definitive diagnosis is obtained by the fine needle aspiration or open biopsy, the detection of the acid-fast bacilli in the direct smears or the growth of the AFB in the culture, and the appropriate anti-tubercular therapy should be given as per these guidelines. That is all my presentation, and I'm very thankful for the organizers to give me the opportunity for the same. Thank you.
Thank you, Dr. Mama. I have one question, that you have told that you will continue the therapy, antitubercular therapy with the betaquins continued till 18 months. So what is your endpoint, and how did you decide the endpoint of this MDR tuberculosis of the
Yes, sir. Yes, sir. That is a good question, sir. Actually, I left the treatment part to the district tubercular officer from the district tubercular center Aizawl.
May I take this question, Dr. Senway?
Yes, please.
Yeah.
Okay. So recently, the government of India is having very robust program for drug-resistant tuberculosis. And before, it was very difficult to take medicines, procure these medicines, taking lots of injectables so lots of patients, they leave hope. Now, every district, and maybe in combining 2-3 districts, there is a drug resistance DRTB center. One is district drug resistance TB center. One is nodal drug resistance TB center. This is the game-changing molecule, bedaquiline. Because of bedaquiline, almost the injection part is nowhere available nowadays. So
Yes, right.
though these are they are just trying to go for shorter regime. In fact, in drug resistant tuberculosis also, but in spot spine or spinal tuberculosis, they are just keeping this in a severe category. And these are most likely nowadays around 17 to 18 months. These medicines were given for 2 years before that all of you had practiced. And this molecule is changing, doing very good work, and drug compliances are also improving. So as we are working in a public hospital, and as Moya also probably is working in government private, I don't know exactly. So this we send all the patients to drug resistant TB center, and believe me, patients are responding very well.
No, it's
Yes.
very, very important because the TB is now a notifiable disease. Whether you are working in a private hospital or a government hospital, you have to not notify once you diagnose a case of tuberculosis. And if it is MDR TB, you must send the patient to DTC because you cannot treat that because bedaquiline is not available, in the private drug stores. It is under control of government and is completely free. You have to send the patient there. They will, the officers are there, and they will follow up the patient regularly, whether the patient is taking medicine or not. The patient under observation. You just cannot treat your own the multiple tuberculosis. It is a notifiable disease as per the government guidelines. You have to send the patient to the particular center, and your hospital knows to which center you have to send the patient to. I have got my own patients who are taking the MDR typical tuberculosis, this thing from the center in the Kolkata. From there, they are taking the medication. You cannot start the treatment on your own. Only thing is that if the patient is sensitive to rifampicin, you can start for the regime. But if it is MDR, you must send the patient to the regional nodal center.
Right, sir.
Yes, sir. Is there is
Thank you very much.
they mail to the district or village medical health officers, and they give the same slip to the patient also. Go and contact there.
Yes,
If they don't go to take the medicines, from the backside they follow the patient, test the patient, and they start giving medicines.
Yeah.
Yes.
Yeah. Thank you.
And if the physician do not send the patient to the district nodal officer, it is a criminal offense. You have to send send a mail and with all the details of the patient and all the reports, and otherwise you will be we the physicians or the surgeons will be in
It is
trouble.
the duty of the hospital in which you are working to send to notify that the government. It is the duty of the hospital. They have to do that.
I have two
Dr. Mama,
suggestions
thank
for
you very much
sacroiliac.
for your nice presentation. It's a very good case and you have managed well. So please unshare your screen. The fourth case will be presented by Dr. Ayan. Dr. Ayan, are you there? Dr. Sanskrit Ayan?
I'm here. Hello.
Yeah, please share your screen.
Yeah.
Sir, options of iliosacral screw and L4 to ilium fixation, MIS fixation in case of sacroiliitis. Any experience with anyone?
So you have to fuse the joint and fix it with the screws. You can use the leg screw on both the sides, and you can take out a block of bone there and put a cancellous bone graft there, fuse it, and fix it with the leg screws.
Sir, we have one experience. For the painful sacroiliac tuberculosis, we have given one iliosacral screw.
Yeah, you
like
can
from ilium to
no
ilium to 6.5 mm, ilium to sacrum, ilium to S2, and ilium to S1 to 6.5 mm cannulated cancellous screw, like
no, you can do
pelvic
that,
surgeons.
or you can just put the two screws on both the sacroiliac joint and compress it. Connect it with the connector. That you can do.
So now the fourth scale case is being presented by Dr. Sanskritya, and he works at Ranchi, Jharkhand. He's a spine surgeon trained in US. So Dr. Sanskritya, please.
Hello, good evening, everyone. Uh, so, so today I'm going to show a case which is of tubercular lumbar kyphosis. So this is a 33-year-old female who came to us with a 8 months history of mild back pain and slowly started noticing a progressive globular swelling in the back. So for the last 1 month, she said she's been experiencing neurogenic claudication. Her walking distance has dropped down to around 200 meters, though she says that the back pain is minimal, and on examination, her neurology was 5 out of 5 in the lower limbs. And this is the first time that she's seeing a doctor for this. So clinically, on clinical examination, we can see a good, like, big size globular kyphotic swelling in the midline. We get an X-ray on the same day, and this is what her X-ray looks like. So we can clearly see that there is a significant collapse. I think someone's mic is on.
Yeah, I have muted.
Okay.
Please go ahead.
So clinically, on X-ray, we can clearly see that there's a significant collapse. So the question was, so just because she did not have any history of tuberculosis or any treatment, so we assumed that such significant kyphosis would be caused by tuberculosis. We get an MRI at the same time, and we see that this is a active lesion with significant soft tissue component also compressing the fecal spine. So the question was, we get a MRI. So would anyone suggest a bending film to see if this is mobile or not? And one thing that I'm pretty sure of is that we need to operate this patient, right?
Dr. Gurdeep, are you there?
Oh, yeah. Good evening, sir.
Good evening.
Yeah.
Your opinion at this stage.
Yeah, if we look at the MRI, we can see a, what do we say, fluid signal in between the L2 and L3. So it's not a completely healed disease. There is some activity going on, and we can see also appreciate the marrow edema in the stir sequence. So there is something going on. So I think if we get the ESR and CRP, we'll also get further corroboration whether this is healed or it is still healing. Like if the patient is in pain and we see that there is significant, I think there will be significant kyphosis and there is some retropulse fragment which is compressing the dural sac. I would agree that probably this case warrants intervention. I feel the options are whether we can go from all posterior or we want to save some segments by going anterior. If we go anterior, probably we can reduce the levels of fusion instrumentation and that will leave some segments free. But having said that, going anterior in a kyphosis and that too in an infection is little challenging. So I would prefer going all posterior here and try to reconstruct the void. So I would probably feel comfortable if I go to L5, but I would see intra-op, whether I can, below the level, if I can stop at L4. And L2, L3, I will see intra-op, whether it is still mobile. I don't think we need radiology to confirm that. Intra-op we can assess. And either we can shorten the segment, remove the disease vertebra and compress the segment between L2 and L3, make it little parallel and go. I think instrumentation above is not an issue. This is the instrumentation below, whether you want to stop at L4 or we want to go to L5.
Okay.
Dr. Sudhir Kumar, what's your opinion regarding this? Dr. Sudhir, are you there? Okay. Then Dr. Tankeswar Baruah, what's your take?
I agree with Dr. Gurudeep. I think it needs surgery and we can address from posterior only. Yeah.
Okay.
So
So
do you
the
do you need a
question,
what the Ayan asked? Do you need a dynamic film to assess the mobility or not?
Can I answer?
yes,
Yes,
sir.
sir.
I think you can take a bolster view supine hyperextension film. Put a bolster there and take a lateral view. That will answer your question whether it is opening up significantly or not. If it is significantly opening up, then the treatment is entirely different. I think you should take a supine
Dr.
hyperextension bolster view. Lateral.
Dr. Nath,
Yes.
Dr. Nath.
Yes, yes. Sure.
So if you carefully look at the X-ray or MRI picture, so it's a typical type of this dislocation is a usually the one body is almost past 2/3 is destroyed,
Yes.
and is stabilized by point contact of the anterior part of the superior body.
Yeah.
So there is usually a facet dislocation.
Yeah, first.
Yeah, facet dislocation is there.
It's obviously needs to be approached from back, and if we want to do stabilize from the reconstruct from front, that's okay, but we have to go to from back.
So
I think
Ayan, please show
yeah.
us what did you do?
Yeah, so Kiran sir actually mentioned a very important thing. So the MRI, most of the MRIs are done supine. So that kind of gives you how much this is going to open uh, just by hyperextension. So the question was again like the anterior approach or the posterior two-level colpectomy, or you'll pry open the collapse. So as Dr. Baruah was already mentioning, that we can either do a two-level colpectomy, remove both the disease vertebrae, or try to pry open the collapse and put in a cage. So I actually went in from the back, and this is a prone position initial C-arm image. This image is after applying pressure from the back, trying to see if this is opening up or not. And this is the maximal opening that we were able to get. So that brings in that important fact that Kiran sir was already mentioning, that usually these cases have a locked facet, and it's so difficult to actually disengage them just by applying pressure.
Please go ahead.
Yeah, so I actually took a chance. So I was sure that we would need to do a posterior surgery first, at least in this case. So we put in the screws, and I put in a rod, trying to see if we can yank this open with the help of a rod. So we applied the rod, and even after application of the rod, this is the maximal opening that we can see. This is a pretty straight rod, actually, you see. It's a straight rod. So the next thing what we do is we start in situ manipulating the rod. So we try to do a in situ bending and dial in some what you call lordosis to that cobalt chrome rod slowly. And finally, after giving in good lordosis, we see that this is the maximal opening that we are able to get. But the problem here is because of the lock facet, the foramina is crunching down. So it's a scissoring effect of the facet, wherein if you try to open it from the front or you pry it open, the neuroforamina tries to close. And that is something which we could appreciate while we had the case open in front of us. So we went ahead and did a facetectomy. And once we removed that lock facet, this is the opening that we could get. So I was just thanking my stars that I did not try to do this open, because if I was doing this from the front, this would have been a very difficult thing to do. Though it was not easy again from the back as well, but we were able to, like, the starting point from where we were trying to put in the cage, we were able to get a good lordosis. We go in further, approach from one side, use a big cage. So usually what I do is I flatten out that cage. So that makes it more oblong rather than round. So it is easier to insert. We put in lots of bone graft in the front. This part, you can appreciate. I was trying to get animation. There's a lot of bone graft in that area. And finally, the amount of lordosis that we get is significant. And on on the same side, we put in a strut, what you call a contained graft, wrapped in a Surgicel to get us some posterior fusion also later on. So this is 10 months post-op. We get a reasonable correction of the lordosis. She's all straight. And this is approximately 3 weeks back. She came to my clinic, and she's otherwise doing well. Thank you.
Wonderful correction.
Wonderful,
Very
wonderful,
Very
wonderful.
good.
Excellent.
Excellent correction.
Very well.
Excellent correction.
Wonderful correction. Yeah.
Nice.
Nice correction. Yeah. So this was a bit of wet lesion, I think, and that is why.
Yeah, so the patient has never had taken ATD. The only thing which surprised me was having such a huge kyphosis, and the patient never had pain as much to come and see a doctor. So the only time she thought she should see a
This
doctor
is the
is
reality
when
in our country.
kyphosis.
This is the
And
reality.
interestingly, she's a nurse actually.
Oh my God. My God. Thank you very much, Ayan. So we are nearing the end of our program. So the last case, you please unshare your screen. The last case will be presented by Dr. Gautam Prasad. Dr. Gautam, are you there? I have to unmute Dr. Gautam.
Yes, sir. Yes, I am here.
Yeah, please
Yeah,
share your
yeah.
screen.
Good evening, everyone. Just so is the screen visible?
Yeah, yeah. It's visible.
Yeah. So this is the case of a 6-year-old. She had been diagnosed with tuberculosis of spine and already operated a year back at Delhi. And this is a condition. She came at 1 year since surgery with the failed implants, the implant jetting out, and this is the poor skin condition. She was unfortunately diagnosed with MDR TB and already on medication. So these are the X-rays. She's still walking, but 6 years, this is the kyphosis level that she has, and the implants are not holding. If you don't do anything, this is definitely going to become a very bad angular kyphotic deformity as she grows up. So I would like to know what will be the opinion of the house.
I think I will put on halo traction first.
Okay.
And then see how much correction in the halo. First step.
So how long you plan to keep her in halo?
At least minimum 2 to 3 weeks minimum.
That's primarily to stretch out the soft tissue fibrosis and all, right?
Yes.
Yeah. So we didn't have that option of halo, sir. So finally, what would you like to do, sir?
The thing is that first thing is counseling the patient party.
Yes,
it's very important to counsel them about these things. Very high incidence of, especially in the thoracic spine at that level, I think it is what is D6, 7 or something. That is very high incidence of neurological deficit. So the patient party should be counseled properly before undertaking any sort of surgery in these patients. And you should always take a written consent, as well as always take a video consent nowadays, for these, because later on it may turn out to be, a big medical legal issue.
Right, sir.
Anyway,
Sir, and this is a poor skin condition. So would you like to have a combined approach or only
see,
posterior or?
you cannot, the bone is so deep, you just cannot go from the front. Whatever you have to do from the back side only.
Right.
You cannot go from the front in this patient because the bone is so deep, you just cannot go there after opening the chest. You have to go from the side and take out, try to take out, apex of the, apical, this thing, gibbous. Anyway, these are difficult cases, but they can be managed.
Yeah, Dr. Tankeswar.
Yeah, very difficult to comment, but still, what I can suggest, take out all implants in one stage and do some release, and one can go for halo kind of traction for some time to get some flexibility, and then after healing of wound and everything, he can plan again. But there is some risk, of course. Yeah.
And the nature of
A lot
the
of risk.
implants, which implants would you like to use? Like, this is a 6-year-old kid already operated. So you will take that pediatric set with 4.5 screws, or because the pedicles are actually very thin in 6-year-old already operated.
Pediatrics set.
I will go with the 4.5 millimeter screw.
Okay.
It is not.
I guess
it is
they
not
have
possible
used
with
this
the
lateral mask previously.
lateral mask screws. I have to remove all the implants first and then go for halo gravity traction.
They can very they can stretch and they can take, I think 5 millimeter screws they can take in the proximity and distally. You can put those things.
Okay.
Because the lateral mask screw, 3.5 mm screws or 4 mm screws will be very thin. They will, come out.
Pedicle screw, yeah.
So I'll just share what I have done, sir, because I don't know whether I'll be still I will have range or not. So this is what we did. We did all one stage. We didn't have the option of halo at our setup. So depending on that screw hold, as many screws I could get in, and even some of the previous LIV screws, the pedicle, the hold were not good, but still the hold was there, which I use it. So this is at the age of 6 years, which we have operated at her. Luckily, this was something in 2018. So comments on this, sir? We did all posterior corpectomy and release, and then shoved in the cage with the graft. And as expected, we continued with the second line ETT for her.
No, that's fine. You have done very well. The thing is that this is a classical approach. You keep the patient prone on the table and go posterolaterally. You take out the ribs and part of the pedicle on the sides, and then you approach the apex of the deformity and try to take out that the remaining part of the vertebra and put a cage there and try to straighten it as much as possible. And always do it, monitoring. I don't know, but in all these cases, nowadays it is mandatory for the cases. This is a very well done case. Excellent.
This is a
She
like
was a really 13-year-old. Yeah. I don't have the results, but she was in outfit just a couple of months. And the whole.
This is like a case of that buckling collapse occurs in children. That is called buckling collapse. There's not so much. Buckling collapse usually more than 120 degree, but it's almost like that. So in that case, this is the best approach, I think. That is called the closing opening wedge osteotomy. So from the what Dr. Ahmed said, you from the lateral side you clear the apical area, and from the back you remove the laminar facets of the distal vertebra, and from the back you closing, and from
anteriorly
the
put a cage, can posteriorly you compress.
so that's called closing opening wedge osteotomy. So it's in this type of buckling collapse. So that's the best approach, I think.
Yeah. So I think how long is the follow-up? 7 years. Gautam?
It's now 13 years, means it was done at
7
the
years follow-up.
it was a 7 year
7 years follow-up. It's a very good case. All the cases were good today. I think with these 5 presentations, all 5 cases are unique and presented well, and also discussed well with our esteemed panelists. So we are going to close this session of the second meeting of uh, East India Spine Society, which is aired through Ortho TV. I thank all the faculty, all the panelists, and our co-moderator and the presenters, as well as the Ortho TV administrators for helping us to reach more and more orthopedics and spine surgeons. I think let us discuss on the next day, next meeting. I have with my calendar. If it will be on the first week of April. It is 1st April. Otherwise, it is 8th April. So, what is the opinion of the house?
I think we should keep it on 8th April. That will be better.
It will be better. So, is there any other opinion?
Yeah, it's okay. 8th April is good.
8th April is good. So next meeting will be 8th April, and I request Ortho TV personnel to support us again in that meeting and air the meeting to their platform. So thank you very much. Thank you all the presenters and the
So we'll
individuals
discuss
who
the topic later on.
Yeah, we'll discuss the topic later on. Yeah.
Okay.
We'll send it in the group.
Thank
So
you.
thanks
Good night.
to
And you are doing very wonderful work. And see the beautiful cases are doing in Ranchi, in our Odisha, Bhubaneswar. So we just came to know that people are so innovative and doing so good work. In fact, Moya also managing so
People are
nicely in
doing good
Aizawl.
work. Only thing is that
Thank
they
you.
need
Yeah.
a platform. They need
Yes, sir.
presentation,
Yes. Please
present
carry
in
on, sir. Please carry on, sir.
platform.
Thank you, sir.
Excellent cases. Excellent case.
And thank you, Dr. Chinmayanath, for taking this initiative. It's a great work. So we should carry on.
Thank you very much for attending and participating. Good night, sir. Good night,
Thank you, sir.
Ortho
Thank
TV.
you.
Please stop airing this session.